Good morning, everyone, and thank you for joining us this morning. Today's webinar with Dr. Russ Federman will focus upon the salient aspects of treating students with bipolar disorder during their university years. Strong focus will be given to the necessary interface of current treatment approaches with the realities late adolescent adult identity formation and conformity with university lifestyle norms. The role of a university-based support group will also be highlighted as an essential aspect of contemporary treatment approaches. Russ Federman, PhD, is in full-time private practice in Charlottesville, Virginia. He's previously had a 22-year career in university mental health. Dr. Federman is a licensed psychologist, a diplomat in clinical psychology through the American Board of Professional Psychology, and a member of the editorial board for the Journal of College Student Psychotherapy. Dr. Federman is co-author of Facing Bipolar, the Young Adult's Guide to Dealing with Bipolar Disorder. He has contributed 2 chapters to our Healthy Living with Bipolar Disorder book, and Dr. Federman currently writes an ongoing blog for the Psychology Today e-magazine titled Bipolar U. Welcome, Dr. Federman.
Thank you very much, Debbie. I appreciate it. I'm really pleased to be talking to the listening audience on this Tuesday of National Mental Health Awareness Week, just 2 days before National Bipolar Awareness Day. Throughout this week, the International Bipolar Foundation is sponsoring their Pay It Forward campaign with the aim of having individuals educate each other about bipolar disorder. So I'm trying to pay it forward today by discussing the challenges of treating bipolar during the university years, and challenging it is, to say the least. I've commented before that, bipolar would be so much easier to treat if the typical age of onset was 35. But the reality is that we generally see bipolar disorder emerge somewhere between the late teens and the mid-20s, which happens to be the ages where much of the population is engaged in university study. It's also a time of tremendous developmental change for the late adolescent and young adult. And this doesn't in any way ease their entry into the bipolar diagnosis. In this webinar, I'll be highlighting important aspects of clinical work as well as necessary university mental health response systems that have to be in place to assist students with their adjustment to the disorder. I'll also be talking about key developmental issues that make the endeavor so challenging. And in the latter part of this presentation, I want to be addressing something a bit different, and that is an essential attitudinal shift that I perceive as really important and necessary to be made by those of us in charge with the task of helping our young adults with bipolar disorder. One of the challenges of this kind of webinar is having such a heterogeneous audience. Like, I assume I'm addressing a mix of mental health clinicians, university students, family members of university students, prospective university students and their families, perhaps even some administrators who are responsible for overseeing the delivery of mental health services on their campuses. Now, if I were to craft this presentation for each group, I'd have 4 or 5 different presentations, which won't work. So my strategy today is to present the issues as if I'm talking mostly to mental health clinicians and administrators. But in doing so, I will also aim to have the material be easily understandable and relevant to others who may be listening into the webinar today, because I understand that there probably are a lot of consumers out there as well. So I want to start by giving you a sense of where I'm coming from with this presentation and how I happen to develop a specialty in working with bipolar disorder. And I can assure you that early in my career, it was never something I had envisioned for the second half of my professional life. I had been in private practice in the late 1970s, probably up through about 1990 in San Diego. And during that time, I had only seen 2 or 3 individuals with bipolar disorder, or at least maybe 2 or 3 where I and they were clear about it. In 1991, I decided to leave the private practice scene, and I was really fortunate to obtain a position as Director of Mental Health Services at East Carolina University. What was unique about the ECU Mental Health Services was that there also existed a traditional counseling center on campus. The mental health services was specifically designed to see students with acute and complex psychiatric issues, essentially those who required more of a medical model treatment approach where medication was an integral part of treatment. Well, as you can imagine, at the mental health services, we saw more than our share of students with mood disorder symptoms, certainly more so than if I had just been a staff psychologist at a large university counseling center where there wasn't a coexisting mental health services. I remained at East Carolina for 9 years, and then in 2000, I was hired to be the director at Counseling and Psychological Services at the University of Virginia. Now, within a short period of time in my being there, my staff recognized that I already had done a fair amount of work with mood disorder treatment, and therefore I received, again, more than my share of referrals of students with bipolar disorder. So over the last 13 years, up to the point of my retirement from UVA this past summer, I found I was gradually working more and more with bipolar students. And by, I'd say approximately 2008, I was probably seeing most of the bipolar students who came through counseling and psych services at UVA. Again, this just sort of evolved away. It was really never part of a grand design for me. But my guess is, at this point in my career, I've probably seen somewhere between 200 to 300 university students that have been diagnosed with bipolar disorder. And I've also run the bipolar student support group at CAPS for the last 6 years. So with that background, let me move on more to the substance of my presentation for today. And I also want to share that I'm going to be talking for probably about 45 minutes, and then I'm going to stop and we'll open it up for audience Q&A, okay? So moving on, the one policy position that I want to strongly advocate in today's presentation is that most students during their first couple of years adjusting to their disorder should receive treatment through on-campus resources rather than being referred to off-campus community providers. Once they've had time to stabilize and they're doing relatively well at managing their symptoms and their lifestyles, then off-campus referrals become more of a viable option. So why is this the case? Well, why am I saying this is important as it is? The predominant theme that we've seen at university mental health over the past 15 years has been increasing utilization of mental health resources. More and more students have been coming to university counseling centers with more acute and complex problems. Now, the reasons why this is the case are complex, and frankly, I don't have the time to go into a full discussion of that. But the consequence of those increased numbers of students is that counseling centers are placing more and more emphasis upon short-term treatment. Essentially, if they're going to treat a growing number of students, then they've got to be careful about how they allocate their resources. And the more sessions they tie up with long-term treatment, quite frankly, the less students they're able to see. So the complex of that is that complex psychopathology requiring strong resources, or to say it differently, those students with bipolar disorder are often referred out. And quite simply, it's because of economics. If they're held in-house, the perception is that it will create a significant drain upon mental health resources. Well, okay, so we have a student who's referred out. They're referred out typically to a psychiatrist, and they're seen, maybe several times until they're stabilized. But once stabilized on medication, they may be seen once a month, once every 6 weeks. And in the lives of an 18 or 19-year-old student, a lot can happen between monthly appointments. And frankly, I find that monthly appointments are not at all frequent enough to really be an adequate standalone option for the young student with bipolar disorder. Additionally, if they're referred into the community, they're not interfacing with enough university personnel so that when relapse does occur, these students really aren't on enough radar screens for university personnel to be able to intervene soon enough to be able to prevent a more significant progression of their symptoms, such that they indeed become hospitalized. If and when that happens, all right, so when the student relapses into acute depression, mania, or manic psychosis, what we see is community disruption, high allocation of campus resources to be able to manage the disruption, possibly a student medical withdrawal. In other words, all of this requires high resource utilization from the university's point of view. So what I've experienced over the years is that referring bipolar students off campus too soon, in other words, prior to their really stabilizing in a way that has some enduring predictability, this unintentionally brings about the same circumstances that universities are trying to avoid. So I guess my perspective is that this just is not a viable option for the bipolar student population. It really makes much, much more sense to invest university resources into the front end in order to avoid negative outcomes rather than putting a lot of resources into crisis management. All right, so if we design a system with that intent, what does it look like? An important aspect of the clinical approach, quite simply, or important aspects. The first and foremost is accurate diagnosis. Adequately diagnosing or assessing and diagnosing the early onset of bipolar disorder or the first onset of bipolar disorder, unless it comes forth with very strong noticeable symptoms, isn't easy. I'm sure that many have heard the data that the length of time between onset of symptoms and accurate diagnosis is a mean time of 10 years or more. That's because the diagnosis is often missed. So I think it's really imperative that university clinicians become highly skilled in assessing and diagnosing bipolar disorder because they are treating students in the age range where they're going to see it first emerge. University counseling centers have to be well-resourced in terms of the kinds of education they're able to provide to bipolar students once the diagnosis is established. Education about their disorder is really, really necessary during the first several months that the student is adjusting. Students also need access to psychiatric medication if needed. And I say if needed because I'm not going to begin with the assumption that all students with bipolar disorder absolutely need to be treated with medication. There are some whose symptoms are on the mild range, as well as there are some who are simply resistant to the notion of utilizing medication. And I think with these students, we begin with lifestyle modification. We begin with other ways that they attempt to manage their symptoms and begin to smooth things out. And you know, if a student is successful in doing that and they can continue on, then great. I mean, I can think of one or two students who come to mind who specifically were dedicated to their yoga and their meditation. And by doing that, in addition to getting good sleep and healthy exercise and stress reduction and all that, they were able to manage their bipolar symptoms without medication. But most of the students that we're seeing who are coming into services with bipolar symptoms, indeed, one of the first lines of treatment is getting them established on medication. There also needs to be, you need to have a staff that is very expert in beginning to work with the denial and resistance of the student early in their progression with bipolar disorder. This is enormous. I'm not going to elaborate on it right now. I absolutely will come back to it, but I'm going to tell you this is one of the most important things I'm going to be discussing in today's presentation. You heard me a moment ago talk about sleep. I think stable, consistent sleep pattern is as potent as good medication for bipolar students. But of course, that's much easier said than done. Getting students to go to sleep at a reasonable hour and wake up at the same time every morning, even on weekends, such that they're getting 8-9 hours sleep on a consistent basis. It's much easier when you're 35, but when you're 18 or 19 and you're just off to college, it's an enormous challenge. So establishing stable sleep is one of the biggest challenges that we face in working with these young students. Regular exercise, stress reduction. I'm sure that many of you have been following media articles about the importance of exercise in addressing mental health concerns. It can be as potent as most medications we use today. And if I can get a student exercising 4 or 5 times a week, and I essentially say to students that if they can become a black belt in managing their own stress reduction, they're far, far better off than if they ignore issues of stress reduction. The bipolar student early in their progression with bipolar, or rather the university student early in their progression with bipolar disorder, also needs to become skilled in developing their own self-monitoring skills. Their ability to step outside themselves and observe themselves with clarity is really essential for them to begin to identify emerging symptoms and then make appropriate adjustments. There's been a lot come forth in the last several years about the effectiveness of mindfulness meditation and a kind of mindfulness awareness. And I really like to work with students around mindfulness issues, and I refer them to mindfulness resources as much as I can. We're also living in an age of electronics, smartphone apps. When I did my book, Facing Bipolar, in 2010, well, actually I wrote it in 08 and 09, smartphones had not evolved to their current state, and I actually put together a hard copy chart. Well, that's Stone Age today, okay? These days, there's a plethora of good smartphone apps that students can use to track mood, energy, sleep, medication side effects. They can correlate that with menstrual cycles. They can do all kinds of stuff. It's simple, it's online, and they can get graphic readout about how all this stuff comes together. The slide you're looking at now lists about 7 or 8 of these apps. I'm not saying this is an all-inclusive slide, but these are some of the better ones that I found online. You know, and I don't recommend one specific app. I really say to students, take a look at them, get a feel for them, and use what you think is going to work best. Going along with treatment, but looking at the importance of the interpersonal aspects, I find that in terms of working with university bipolar students, their participation in a campus-based bipolar support group is essential. And I'm going to come back to this, but again, it's one of those things where I'm saying it is amongst the most important things I'm conveying today. But I will come back to it. Parents are at home. Parents are not on campus with students. And if the student is early in their management of their bipolar disorder, parents are worried. Parents really need to communicate with the treatment team. Now, of course, bottom line is that this is up to the student. The student needs to be able to provide release and allow their providers to talk with parents. But if the student is comfortable in doing so, I think the whole system is better off if we're regularly communicating with parents and keeping them in the loop rather than having the parents only communicating with the student, because they get a very different picture when they talk with the providers versus just the student. I also strongly encourage students to do their best to develop a small peer support network. I'm talking about 2, 3, maybe 4 friends they have on campus who know about their diagnosis and who know about their symptoms. Ideally, this should be a roommate. Now, I get it that not everyone becomes close friends with roommates. But if a student does, then I think for a roommate to know what the student is struggling with can be very helpful. And for 1 or 2 others to know as well. Because if those connections are not made, you only increase the extent to which the student experiences a profound sense of isolation and aloneness in relation to the disorder. In terms of the broader system, I find it's really critical when a student calls the counseling center and identifies that they think they may be bipolar, or even if they don't know the term, but they describe symptoms and it has a bipolar feel to it, for the counseling center to be able to have the flexibility to schedule a 90-minute intake for the bipolar student as opposed to a 50 or 60-minute intake, which is much more standard. In doing this work for many years, I simply find that accurate diagnosis of bipolar disorder is a complex endeavor, and it needs time. And I think a 1-hour time slot simply is inadequate to be able to do a thorough job. In fact, if I had the time and if I had a student coming in and I knew they were bipolar and I knew this might be their first approach to treatment, if I could, I would set aside 2 hours, because I think it really takes that much time in the first session. The Counseling Center should not be standing alone in this endeavor. There are many other offices within a large university. The Dean of Students Office, the Office of Disability Support Services, the Office of Residential Life, offices associated with sororities and fraternities. Essentially, the Counseling Center must have excellent working relationships with key student affair offices, as well as the external agencies, in other words, those places off campus where if and when a student destabilizes and they may be managed for crisis, the Counseling Center has excellent connections already established, be it an emergency room, a local crisis center, a local hotline, the police, all of that. We've heard the phrase before, it takes a village. Well, it does, and the Counseling Center is only one part of that village, and they need to be very well connected to other components. Now, I'm coming now to the issue I identified at the beginning, where I said that I'm addressing or I'm approaching a kind of attitudinal shift. You know, 7 years ago, I don't think I would have placed as much emphasis on this as I am now. But at this point, after treating as many students as I have, I've come to believe firmly that it's one of the more important issues we need to be addressing. And what I'm referring to here is that there must be a system-wide recognition that the undergraduate student, somewhere between 18 and 22, really is not ready to face the reality of his or her bipolar diagnosis. The impact upon them is enormous. They feel derailed. They feel knocked off course. They feel like they've been faced with something that they're not at all prepared to manage. In fact, I think the implications are literally too much for the young adult to fully let in and to rapidly come to terms with. You know, I used the big scary monster in this slide, not because I think about bipolar disorder as being a monster, but I think that for the late adolescent or the early adult, the enormity of what they're being asked to do in relation to their disorder is synonymous with how they would feel if they were standing in front of a monster like this. I might add here that, you know, it's very rare I see an undergraduate student who simply accepts the diagnosis and makes all the necessary adjustments without a significant degree of struggle. It just doesn't happen. And so I think that what we really have to recognize is that as students are initially diagnosed and initially trying to come to terms with what this all means, providers must understand all the different factors that interfere with their acceptance. They've got to understand that most students will likely reject the diagnosis, and I don't mean intellectually, but I mean at the level of deep acceptance. You know, it's more like they agree that they're bipolar, or at least they understand it, and they hate it. And as a result, they stumble. They experience episodes of relapse. And through their struggle, they gradually learn, gradually come to accept their reality. Our role as providers and administrators is to be patient and encouraging of these students while also providing empathic support and guidance. The student has to feel absolutely safe in coming back to us and saying, I've screwed up. I haven't done what you advised me to do. I feel like I'm back to square one. You see, essentially, we're trying to accelerate an adjustment process that is usually quite slow and gradual. And as mental health practitioners, we've got to understand this and learn to proceed accordingly. So, you know, why this inevitable difficulty with acceptance? Why is this such a big deal? Well, I want you to first just to consider where the first-year college student is at. It may possibly be their first extended time away from parental control, you know, away from home base. They've been anticipating this transition for years. You know, in college students, in high school students are thinking, God, I just can't wait to get to school, can't wait to get out, can't wait to kind of start this next big phase of their lives. Now, in addition to moving away from parental influence, there's also an opposing movement towards new attachments as the basis for new sets of identifications. There is a strong need for a sense of connection and belonging, because keep in mind they're leaving a home that they've known for many, many years and a community that they've known for years. They're going towards a lot that is new, and how do they find their foundation amongst that which is new? They find it through social connection, and so it becomes a very, very important factor for the late teen or early 20 bipolar individual. You see, what I'm saying here is that the university student with bipolar disorder, they really want to experience the freedom of no parental control, or at least much less parental control. No curfew, no checking in, no having to be accountable on a day-to-day basis. They really want to fit in and be accepted as normal. And that's not easy when they're not feeling normal. They want to be able to do as their peers do. They really want to be one of their peers. They don't want to be seen as different, as having a mental disorder. Our college students are intensely involved in preparing for what comes next. And this process of preparation strongly stimulates image of who the individual is striving to become. And I assure you that that image of who they're striving to become does not entail, at least not if they've not previously been diagnosed, it does not entail having bipolar disorder. You see, none of what they've previously known, if they've not previously been diagnosed, has entailed living with the unpredictability and the self-imposed limitations required of the young adult with bipolar disorder. So what do we do, both as providers and as systems, to begin to offset some of these critical developmental factors that are influencing young students? First, as I've already addressed, it's important that we maintain an attitude of one understanding and acceptance of bipolar students. They're not something that we need to get rid of from our campuses. We need to be able to embrace them, integrate them, and learn how to best help them. University administrators need to be working with university populations to lessen stigma around mental health issues. So I really encourage the kind of anti-stigma campaigns that we see occurring on university campuses. They're crucial. So the more we can be talking about mental health issues, the more out in the open we can be about it, the more accepting students can be about it, the more comfortable a student will be in picking up the phone, calling the counseling center, and saying, I think I need help. And last, and again, this is a key component of what I'm talking about today. That is, we need to provide peer-based experience for student identification and establishment of healthy, alternative lifestyle norms. What am I talking about here? I'm talking about the utilization of a student support group as being very central to treatment. What does the support group do? What does it accomplish? And how does it fit into this broader picture? Well, you heard me talk earlier about the once-monthly psychiatric sessions. The good news is that a support group allows weekly monitoring and weekly adjustment of any medications as need be. You get to have at least one professional lay eyes on a student on a weekly basis. And so even if they're not seeing a psychiatrist but once a month, they're having weekly contact with someone in the mental health field. They get to experience a sense of peer understanding and acceptance, a sense of belonging, I can't convey to you how impactful it is for a student who is new to a bipolar support group to talk to the other group members and then to see in their faces perceptions of recognition, perceptions of agreement, perceptions of, yeah, I've been through it too. And so rather than feeling alone and different and strange, they get the sense that, geez, these folks know what I'm talking about. Essentially, they have a sense of belonging, and that is critical for the student who's struggling with the early phase of a bipolar disorder. Now, if a group is successful in establishing alternative norms, norms around sleep, norms around minimizing psychoactive substance abuse, then those alternative norms can be used to begin to offset the influence of what they see their friends doing. You know, if you're in a fraternity and your brothers say, come on, let's go to a party, it's very, very difficult to say, you know, I can't. I really am trying to refrain from drinking, or I need to get to bed early enough. And yet, if on a regular basis you're meeting with other students who are also trying to refrain from becoming intoxicated and trying to stabilize their sleep patterns, then the college student can at least kind of conjure up within their own mind the recognition of that group that they belong to, and that can help them to begin to offset some of the social influences that they struggle with on a day-to-day basis. Within a group setting, students get to receive peer instruction on how their peers have coped with some of the struggles that are common to bipolar disorder. You know, I can talk with a student after having had many years of mental health experience, and I can say whatever I may say with clarity and authority and all that, but it doesn't have anywhere near the potency or the power as if that same message comes from their peers. Because when they hear it from their peers, especially their peers who are also bipolar, they get it. It just has a whole lot more validity. Also, if you think of a group of students where you have students at various stages with their disorder, you may have some graduate students who have had their disorder for numerous years. You may have other students who are in the first or second month of coming to terms with their disorder. The students can look towards the more seasoned students, and they really have some nice modeling of how these older students have adapted. So you can see some mentoring relationships develop within a group that can be profoundly helpful to the bipolar student. I spoke earlier about the emphasis upon resource allocation, and we can't ignore that that's a very real factor for university administrators. Well, if a student comes into treatment and they begin with, let's say, 6 to 8 sessions with individual psychotherapy to help them receive the diagnosis and help them begin to adjust to the diagnosis, and they are then referred into the group for ongoing weekly attendance, all right, then you're not tying up, 5, 8, 10, 15, 20 different individual therapists across a whole counseling center, all of whom are doing long-term work with bipolar students. The support group can be their primary treatment resource. Now, once they are in the group, if and when they experience some periods of instability and they need some individual assistance, then they can always be referred back to the individual therapist who saw them, and that individual therapist can see them briefly, see them 3, 4, 5 more times, and help them get through a rough period, and then the individual therapist backs off again, and the individual continues on in group. So I also see that the group resource can help to both save against excessive resource utilization, but also can be there in the midst of a whole realm of mental health providers who can then come into play as needed. Lastly, the individual therapist, the group therapist, and the psychiatrist should all be communicating on a very regular basis. And when they do, then you have highly integrated and well-managed treatment. Essentially, the mental health treatment team it really is a team. We're not talking about any one individual working with a student. We're talking about the village, the counseling center village, so to speak. Some counseling centers these days also employ case managers. A case manager would be someone who oversees the case and tries to integrate the components of individual therapy, group therapy, psychiatric medication, and any interface that the counseling center might have with other offices across campus, such as Office of the Dean of Students or Res Life, or even faculty and deans. And the last thing I want to address here is the role of disability support services on a college campus. You know, if a student is diagnosed with bipolar disorder, they are eligible for assistance through disability support. They have a bona fide learning disability, and there are accommodations that they can receive that will help them tremendously at times when they really need it. You know, my experience has been that many students are resistant to this. Many students say, no, I don't want to have special accommodations. I don't want people to treat me differently, et cetera, et cetera. But I find that once students can get beyond this, and once they realize that if for 3 or 4 days they're too depressed to be able to get up and get to class, or if they're hypomanic and they just have a difficult time sitting and maintaining focused attention, that they can go to the professor and let them know, or they can email them and call them and let them know that they're unable to attend class because of medical reasons, and they're not going to be penalized for it. Or if they need additional time for test taking or things of that nature. It is an important adjunctive piece of assistance to be able to bring to bear upon the work with bipolar students. So, you know, in closing, and I've actually gotten through this a bit faster than I anticipated. I hope I haven't talked a mile a minute. But in closing, I put together a lovely little chart here of the different components that I have been talking about. Here we see our first or second year enthusiastic bipolar student walking across campus with his backpack and his books. Actually, he looks like he's more in high school, but that's the image I could find. And you see the various roles that I've been addressing and how they all interface. So these are important pieces to keep in mind in putting the whole puzzle together. Well, as I said, I've moved through this probably about 5 or 6 minutes faster than I anticipated, which is great because we have more time open for questions and my own response to it. So let me turn the webinar back over to Debbie Smith, and Debbie, you'll be managing questions and I believe sending them to me. Okay?
Yes, thank you, Dr. Federman. So I'm opening this up for questions. Here we go. Okay, here's the first question. The clinical aspects of bipolar you discussed describe college life, no sleep, stress, etc., almost the perfect storm. So how do they take care of themselves in an environment that is counterintuitive to their needs and they're trying to fit in? And secondly, how do we educate parents and students prior to college entrance if they don't have a diagnosis yet?
All right, my response to the first part of the question really has to do with all the help that I'm talking about, which is, yes, I agree. The university setting can be a perfect storm. And connecting, and once the student identifies that they are bipolar and that they are struggling, it's incumbent upon the university personnel to help connect them to all the various pieces that I've been discussing. And I also want to agree that it is not easy. It is also why I said earlier that we have to recognize that many students early on struggle, they stumble, they do relapse. They don't necessarily make it through the first year successfully if it's the year of their initial onset with the disorder, because all that they have to manage really is too much for them at that point in time. So I guess I'm going to say that I'm not sure that it always is manageable. I think universities are doing their best these days to bring resources to bear, or to make resources available for students who are struggling. But that said, sometimes the challenges that students face are simply too much, and they may have to withdraw. They may have to get some additional treatment, move home, spend some time at community college, kind of strengthen their foundation and get ready for their return, and then hopefully recognize that as they return to school, they've got to make some shifts and adjustments that they weren't fully aware of the first time around. Could you remind me of the second part of that question?
I'm sorry, can
Debbie?
the listener send the second part of that question again?
What?
In the meantime, we'll move on with the next question.
All right. All right. I'm sorry about that. I kind of got carried away. Oh, wait. I remember.
Okay.
It was how do we educate parents and students about these kind of pitfalls prior to their arrival at school. Well, I don't know that we do a real good job of that. I think International Bipolar Foundation has been doing a really wonderful job of getting information out on the airwaves. I mean, out across the internet, and there are numerous other organizations that are undertaking similar efforts. But as we know, if you don't already know that you have a child with bipolar disorder, you're not going to be necessarily going to webinars and information provided by IBF or other organizations. When I was director of counseling and psych at University of Virginia, I was part of student orientation at the beginning of each year. I would have an opportunity to speak in front of the parents of first-year students, and I would talk with them about a lot of what I'm talking about today. And I would let them know that a high percentage of first-year students will struggle, will experience anxiety and stress and other symptoms. Some of them may even indeed come down with more serious psychiatric diagnoses like bipolar disorder, and I make it real clear to parents what the resources are and what they can do if and when such occurs. But can we truly educate all incoming folks such that they know this stuff ahead of time? I think that's a tall order, and I think we're not there yet. I think that we need to be putting more energy into that over the next chunk of years. So let's go on to the next question.
Okay, thank you. Within the bipolar support group, would you encourage out-of-group contact? And if so, how long would you recommend students engage in the support group? Example, their whole time at the university?
Yeah, well, first I would engage I would encourage out-of-student contact, but I really make that clear to the group that is up to them. It's not something I want them to be doing, but if students do want to connect with each other, I find that sometimes that can be a very, very valuable resource where they can be there for each other. Has that ever backfired? In other words, have students ever felt kind of burdened out or overburdened by the needs of any one student? I haven't seen it in the last 6 years that I've been doing it, but that doesn't mean it could not occur. And I think that just has to be dealt with at the time that such would occur. But I can also share a lovely anecdote with you that it's just one of my favorites, and that is I'm remembering a group in which we were in early spring, and a student was showing her annual signs of hypomania. She was very sensitive to seasonal changes. And here we had a gorgeous spring day, and she was just full of springtime herself, and her energy was up, and she was happy, and she was laughing. She wasn't sleeping. She was just talking about how great she felt. And of course, the group members who knew her well enough said, "So how are you sleeping?" And she said, "Oh, I'm not sleeping much, but that's okay. I'm feeling good. I don't really need to be sleeping much these days. I have a lot of work to do besides." Another student said, "Well, have you been taking your meds regularly?" And she said, "Well, I've been taking my antidepressant, but I ran out of the antidepressant. I really want to get a refill because it's helping me to feel so good." And I had a number of other students kind of look at me and at her with alarm. And I said to the students in the group, "So what thoughts do you have?" And a number of them chimed in and expressed their concern and expressed that even though she might be feeling good and feeling like she didn't need sleep, they thought that getting good sleep probably was very much what she needed. And one student was kind of educated enough and sophisticated enough that he piped up and said, you know, and if you're feeling this way, an antidepressant is the last thing that should be taken. Well, as it turned out, the student had gone into a pretty significant winter depression, and our psychiatrist was using Wellbutrin with the student, and it was helpful. So it wasn't an inappropriate medication, but as springtime shifted, she needed to be withdrawn. And anyway, the conclusion of this story is that after group, 3 or 4 students walked her back to her residence hall. They picked up her prescription for sleeping meds that she had back at her residence hall. They walked with her to CVS pharmacy. She got it refilled. They made sure she didn't refill the antidepressant prescription, and we got her in to see a psychiatrist the next day for subsequent medication adjustment. So it was an incident where the group was really instrumental in working with this hypomanic student, and their out-of-group contact made all the difference in the world. And I've got many other examples where I saw stuff like that happen, and I found it to be very helpful.
Okay, thank you. The next question, what suggestions can be made to a student with a few weeks depressive episode in terms of motivation and staying focused on coursework?
Would you read that one more time?
Sure. What suggestions can be made to a student with a few weeks depressive episode in terms of motivation and staying focused on coursework?
Well, one of the things that I'm always saying to students is that their depression is transient. Now, when the student is in the midst of the depression, it doesn't feel transient. Each day feels like it stretches on forever. And yet you need to be an external voice which says you will get through this. This will lift, and we will do what we can to get you the necessary help to accelerate the resolution of the depression, at least as best we can. And then you simply be the voice of reason, which is if you just put everything on hold, you're going to be facing a pileup towards the end of the semester, which is going to be too much to manage. And rather than coming out of the depression, you're going to feel even more depressed by the overwhelming mountain that you're looking at. I often then try to serve as an advocate by asking the student if he or she would allow me to have a conversation with their academic dean. And I'll also encourage the student to speak with the academic dean, such that we want to get someone in the academic sector aware that the student is struggling, that the student is having a hard time keeping up, and also convey that information to their professor, hopefully so that the student isn't faced with negative consequences. If the student feels some degree of relief that they're going to have some leeway and that they're not going to be held to the same standards as other well students, then they may be able to be less hard on themselves, and that may assist them to get through the depressive episode. I also regularly talk about things like getting out and getting daily exercise and getting their systems activated. It's one of the most important things we need to do when a student is depressed. If all the student does is just sit around, the student is not going to feel better. And so I come at the students strong. And I try not to do that in a kind of strong, authoritative, drill sergeant manner, but I say to the student, look, you have a choice here, which is if you sit and do nothing, I can almost guarantee you probably won't feel better quickly. But if we can get you out every morning, if we can get you walking a mile or two every morning, if we can get you eating good food on a regular basis, it will accelerate this process so you're not stuck in it for so long. And I kind of become the cheerleader from the sidelines saying, come on, let's get you moving. And frankly, some students respond to it and some don't. And that's when providers also have to recognize there's only so much they can do. And if a student falters and doesn't get through it, then you got to be there to help pick them up and help them adjust to the consequences of the depression and possibly lessen their course load or possibly even facilitate a medical withdrawal if they find that they're just not functionally capable of doing the work. Okay, next question.
Okay, thank you. Are there additional considerations for the increased stress and expectations of graduate school, including for patients who were diagnosed as undergraduates and have had some experiences with the condition?
Well, I'm not quite sure what is meant by extra considerations. What I find in looking at a large number of students is that graduate students are often more successful in managing the bipolar disorder than are undergraduates. Quite simply, they have 3 to 4 years or more years of maturity under their belt, and that maturity makes a huge difference. So when I look at the 25, 27-year-old graduate student who is coming into the University Counseling Center with bipolar disorder, I find they're generally better able to make the kind of lifestyle adjustments that are indicated. Now, I think one of the challenges is that there isn't the kind of support system that you typically see in place for an undergraduate. So the graduate student, particularly if they've come to a campus, and maybe they've come to the campus specifically for graduate school, they may feel much less integrated into the campus community. And so as a mental health provider, I then need to do a lot of work to help this individual connect with resources on campus that will help facilitate the student's sense of inclusion in the university community. Because the last thing you want is for the student just to be going home and sitting in their apartment alone during the midst of a bipolar depressive episode. So I think sometimes graduate students really need some unique specialized help. The flip side of that is I find that they have more maturity under their belt and they're better able to handle the stresses that they're faced with.
Okay, thank you. Next question. Additional considerations or recommendations for universities with predominantly commuter student populations?
Well, I think that's a whole other ballgame. I mean, we're either talking about community colleges, or we're talking about, let's say, a more urban campus where you don't have the traditional undergraduate setting that you do when you have a college town and you have a large number of residence halls or dormitories. And I think in those settings, students really then do have to rely on community resources. And some of the advice I give to parents is if you know a student is going to school and you know ahead of time that they've already got the diagnosis, you absolutely need to be sure that the student is going to a setting where they have good access to the necessary resources. Now, in a larger urban area, there's going to be no shortage of resources in a moderate-sized city or a larger city. There are many resources, and so I think university administrators need to be able to help students connect with those when they are in times of need. But at the same time, if you're thinking of sending a student to a commuter type college, and there are not many resources available in the community, coupled with the fact that there probably are not a wide range of resources available through the campus, I think ultimately that's a bad idea. So there's got to be a lot of preparation and planning before going to school if you are a student and a family where there is bipolar disorder.
Thank you. Next question.
Next question.
You mentioned that university counseling centers need to be educated about bipolar, but how do we help the university as a whole and the educators understand this? My son attended a private university and was completely under the radar?
I see it happening gradually. I don't think that we're going to quickly see that all people throughout a university community are aware of the complexities that are entailed with more of a complex psychiatric diagnosis. But I do know that, well, as a director, I was very active within an organization called the Association of University and College Counseling Center Directors. It is the association where university counseling center directors find their peers. And we, as a group, were always talking about the needs to educate campus communities about mental health issues. So, for instance, at UVA, let me see, a year ago, we brought, there's a documentary film out there called Of Two Minds, and we brought the film to campus and did a lot of PR and advertising, and I think we had an audience probably somewhere around 250 people. And so there was very broad exposure in that evening to community members, and we had an open panel discussion afterwards, and we openly talked about many of the challenges that individuals face who live with bipolar disorder. I think the more universities can hold events like that, whether it's bringing in movies or bringing in drama productions or holding open panel discussions, any and all the above, it's important. You know, these anti-stigma campaigns are important, but we're approaching them gradually. And it's really unfortunate to hear that your student thought he was under the radar screen and that he struggled. I know that may be the case at some schools. It's certainly not the case at all schools. And there are some schools that really have a high degree of mental health awareness, and I think those schools probably do a better job of responding to students than others do. Next question.
Thank you. It's not uncommon for students with bipolar disorder to self-medicate with alcohol and thus wind up dealing with both issues. Suggesting for teasing out the two and helping judgmental university personnel about co-occurrence of mental illness and substance use disorders.
Yeah, right. Well, I think that hopefully, I say hopefully because I really can't speak for all mental health clinicians, you know. I've found that clinicians at large, well-resourced university counseling centers are well educated about the comorbidity of substance abuse and psychiatric disorders. That doesn't mean that they're very effective in treating it. And my point there is that as I was talking about the issues of resistance and denial that were so prevalent in university students, often they use alcohol and substances as a way of self-medicating and as a way of staying away from the medical mob. And parents can say all that they want to say, or administrators can say all that they can say to these students, but until such time as the student himself or herself recognizes that their utilization of or their use of alcohol is counterproductive and maladaptive rather than helpful, then they're not going to be able to turn that around, and often that takes time. I do think university mental health folks very, very actively work with that, but it's not a simple process and there aren't simple solutions. I wish I could be more encouraging in that regard, but it's something that I think all of us in the trenches are just working very hard to gradually change. So I recognize that we're just about at the end of the hour. I'm assuming we don't have time for any more questions, or am I wrong?
We have one last question. My daughter works in the inpatient psych unit at Stanford and sees a lot of bipolar patients. Do you feel that stress for students is increasing symptoms and triggers for bipolar? And are you seeing more patients with bipolar now than years ago?
My answer is simple: yes, yes, and yes.
Okay, great. Thank you so much.
I really don't have more to say, except absolutely, stress is a big factor, and it is impacting university students, and we're seeing higher numbers. Yes.
Okay, thank you so much for your presentation. That was wonderful. And thank you all for joining us.
Okay. So are we done?